All right, arrhythmias. For your information, exam 3 is not just arrhythmias, right? So don't go crazy. I know this is new for most people. Don't go crazy on this. We're only doing the basic rhythm interpretation. And for fairness, since you don't have any experience with telemetry yet, because one rhythm can look different in each person, okay, because there's a difference in the amplitude. Once the amplitude changes, then the rhythm looks different, okay? So it's not going to be exactly the same, okay? So let's say if four of you have normal sinus rhythm, you may have different because the heart rate's different for each one of you, and then the amplitude, like I said, you know how high the intensity of each electrical impulses makes the rhythm look different. Okay, that doesn't change that it's still normal sinus rhythm. So for the exam, for exam 3 and also the final exam, all the rhythm strips that I will be using comes from your textbook. Okay, only in this chapter. Right? Any questions? All right. And there are basically 5 questions, 5 possible questions for each rhythm. Now, it doesn't make a difference also whether it's my exam or the NCLEX. NCLEX will ask you the same thing. They will ask you, number one, what does the rhythm look like? Okay, what is this rhythm? And then you identify and then you answer. Second question is, what causes it? Meaning, when we say what causes it, that means we know who are at risk at getting that type of dysrhythmia. Okay, the third question is, what are the signs and symptoms? Now, the signs and symptoms is easy because all dysrhythmias, although they vary in severity, all of them do the same thing, which is they will reduce cardiac output. Okay, because of the abnormal rhythm, that means it will affect blood movement in and out of the heart. And because of that, blood pressure will suffer. Okay, cardiac output will suffer. So therefore, all dysrhythmias will have the same manifestations, okay, which are all signs and symptoms of what? Reduced cardiac output. Okay, so remember heart failure. Okay, so what did heart failure do? Especially acute heart failure, what happened to cardiac output? It dropped. Okay, so the same signs and symptoms you learned in decreased cardiac output in left side heart failure is going to be the same here. But again, each dysrhythmia has a different severity. Some sinus dysrhythmias are harmless, therefore, typically no symptoms. But even for some patients who have dangerous dysrhythmias, they may be totally asymptomatic, right? So that's why the rule is whenever you see an abnormal rhythm, the first action is to go check your patient. Okay? You don't treat the rhythm necessarily each time. You go and see how is the patient doing? How is the patient tolerating the dysrhythmia, right? And then, of course, if they have symptoms, then we treat them, right? The fourth question is the treatment. What do we do? Now, treatments can be pharmacologic, which is most of the time. Sometimes it may be non-pharmacologic. For non-pharmacologic, which involves a doctor performing a procedure or a maneuver, the questions will be our nursing responsibilities when the doctor is making that maneuver. Meaning you're there to assist the patient. If anything goes wrong, you are there to help the patient. Okay, you're not like leaving the doctor. Oh, that's his job. Okay, I don't want any part of that. All right. So for of course, if you're giving the drug, you're choosing the pharmacologic intervention. Then since you're the one giving the drug, then who's responsible for the side effects? Then you are. Okay. Yes, you have a question. We'll discuss that today. We'll learn that today. All right. And then the fifth possible question is patient teaching. What do you teach the patient who has these dysrhythmias or who are at risk for these dysrhythmias? Okay. So let's recap. What are the 5 possible questions on each rhythm? What does the rhythm look like? Second, what causes it or who are at risk? Because if you know what causes it, so let's say you know that straining causes it. So therefore, how do you prevent it? straining, like giving birth to a third, causes a certain type of dysrhythmia. Okay, there you go. All right. And what's another possible question? Number 3, signs and symptoms. Then number 4, interventions. So either pharmacologic or non-pharmacologic interventions. And number 5, what do we teach the patient? Right? So just keep it simple. Okay, so let's start now with the basics. So arrhythmias, like I said, are caused by several factors. So some of them are caused by even medications. So that's another thing we need to learn, that our anti-dysrhythmic agents or our pharmacologic interventions can cause a different dysrhythmia. Okay, that's just a natural side effect. Meaning when we give medication to treat one dysrhythmia, you should anticipate that the patient may develop a different dysrhythmia after administration of that drug, right? We have no choice. This is the nature, because how do you suppose the drug resolves a dysrhythmia? Doesn't it interrupt the electrical conduction? Yes, and by interrupting that electrical conduction, then they can potentially cause a different dysrhythmia, right? Meaning, or let's say you're giving a beta blocker to treat a really high heart rate. Say the patient is in supraventricular tachycardia. Okay, the heart rate's 180, 200. So what do you give? A beta blocker, for instance, right? So when you give a beta blocker, what possible dysrhythmia may result? Bradycardia, okay, which is the opposite, because since it lowers the heart rate by interrupting the electrical conduction, then it could potentially cause a bradydysrhythmia. Make sense? Okay. Okay, let's review first. What is the normal electrical conduction of the heart? How does our heart work? Okay, unlike other muscles in the body, the cardiac muscles are unique because they can generate their own electrical impulses, meaning the cardiac cells are highly specialized. Okay? They have the ability to generate electrical impulses. And because they can generate it, they can also transmit those electrical impulses. During embryonic development, so let's say from when Kayla was conceived, for instance, so Kayla was a single cell egg, right? And then her dad said something to her mom, and say, suck. And then, long story short, Kayla from one single egg became 2, 4, 16, and so on. Now Kayla is a complex human being. One of those cells evolved to become the heart muscle, the heart organ. So at one point, therefore, the entire heart organ was one single stem cell. And then it developed and then became more specialized. So some cells became pacemaker cells, some cells became the ventricles, some became the pericardium, and so on. Okay, but everything in the human body came from one cell. So therefore, at some point, all of the cells in the same organ possess the same characteristics. Of course, after maturing though, as the organ developed, they became more specialized. Okay, so just like in nursing, for instance. Okay, so when you enter nursing, you're a general med-surg nurse. If you want to specialize, okay, now you go into pediatrics, okay, or go to mother and baby, for instance, or you go to ICU. So now you specialize. Okay, so same thing with the human body. All right, so we have pacemakers. So I mentioned that the heart is able to generate its own impulses, but as the heart organ again matured and became fully developed, the pacemaker cells are now specialized, meaning we only have 3 sets of pacemakers in the heart. The primary pacemaker is called the SA node or the sinus node. This thing is located in the right atrium, right at the door of the right atrium from the superior vena cava. And this thing is capable of firing 60 to 100 impulses a minute. Okay, 60 to 100 times each minute. There is a secondary pacemaker. This time, this is located in the junction between the atria and the ventricles. We call it the AV node. We'll look at the picture in a short while. Now, the AV node is a secondary pacemaker. I repeat, it's a secondary pacemaker, meaning it is a pacemaker. The moment the SA node fails, meaning if there are no impulses transmitted from the SA node, the AV node takes over. However, since it's a secondary pacemaker, it's only capable of firing 40 to 60 beats a minute. It can sustain life, but can we depend on 40 to 60 beats per minute? No, that's not really compatible with life, right? So it's only a backup. Okay, it's only a secondary pacemaker. Now, the third sets of pacemakers are the left and right bundle branches all the way to the Purkinje fibers. Like I said, I'll show you a picture shortly. So these tertiary or third set of pacemakers are not worth talking about because they can only fire 20 to 40 beats a minute. Now, can that sustain life? No. So we won't bother talking about these because these will not help us at all. Okay, these cannot support life. Can you live on 20 to 40 beats a minute? Even when you're sleeping, you can. So here are the locations. Sorry. Oh, where's the picture? All right, so here's the photo. All right, so you see there the SA node, the AV node, and then the left and right bundle branches, as well as the Purkinje fibers. All right, so look at the pathway. So if this is Fernando's heart, so you can see the SA node is closer to his right shoulder, correct? And then you can see the AV node and the pathway, meaning as the electrical impulses is fired from the SA node to the AV node and then all the way to the ventricles over to the last Purkinje fibers. So it goes diagonally, right? From the direction would technically be from the right shoulder all the way to his left foot. Okay, so that is the direction of the electrical pathway of the heart. So electrical impulses traveling through the heart 60 to 100 times a minute happens in the direction of from the right shoulder all the way to the left foot. Okay, I'll show you why that is significant later. Any questions so far about the pacemaker? All right. Yes. Yeah, when we say pacemaker, meaning it generates an electrical impulse. Okay, so when it generates an electrical impulse, so it stimulates a heartbeat. Okay, so I'll show you later when we go to the waveforms. Okay, what comprises a cardiac cycle. Okay, a cardiac cycle is basically one heartbeat. Right? Okay. Any other question? Okay. So again, what makes the heart organ unique from the rest of the body? Can generate its own electrical impulse, unlike other muscles of the heart. So let's take skeletal muscles. So your arms, your biceps. Mr. Anthony, for instance, is a very good specimen. Okay, I hope you don't mind me use an example. Okay, so you see he has very well developed muscles, right? Just like me. So we're about the same. Okay. So, however, unlike the heart muscles, which can generate their own electrical impulses, the skeletal muscles cannot. Skeletal muscles depend on the brain for stimulation, meaning without stimulation from the brain, can the skeletal muscles work? No. Okay, so that's why you see paraplegics, for instance, quadriplegics, those that suffer spinal cord injury, or after a stroke, for instance, what happens to the muscles? Totally useless. Okay? So the patient becomes paralyzed. Because unlike the heart, can you paralyze the heart? No. Okay, because the heart can generate its own impulses, meaning somebody could be brain dead, meaning no brain function, but as long as you have circulation, meaning there's ATP, for instance. The patient has um, um, some fuel, the heart will keep moving independently of the brain. Does that make sense? Okay. A few terms we need to learn here are depolarization and repolarization. Depolarization is also synonymous with a contraction. When the atria and the ventricles contract, the technical term is atrial or ventricular depolarization, whereas repolarization is relaxation, okay, of the atria and the ventricles. All right. They're also the same, meaning they coincide with certain periods of the cardiac cycle. So depolarization makes systole possible. Okay, so depolarization is the same as the systole period. And of course, relaxation is repolarization. So therefore, that is the same as diastole. All right. So what do we call it again when the heart muscles are contracting? Depolarization. What about if they are relaxing? Repolarization. Okay, so how does that happen? So imagine a cell. So let's look at this whole screen here as a cell. Okay, this is the inside of a cell. Now, what makes the cell depolarize? When we say depolarize, it will discharge its energy. Okay, so what makes it do that? Well, the influx of positive and negatively charged electrolytes, okay, specifically potassium, sodium, and calcium, for instance, as they enter and leave the cell, they change the polarity of a cell, correct? Meaning as blood pressure pushes blood circulation throughout the body, they push certain electrolytes inside and push some electrolytes out. So the entering and exiting of the electrolyte changes the polarization, meaning the charge of the cell, meaning it will make the cell change the polarity from negative to positive. And the more positive the cell becomes, there's so much power in there now, right? So much energy. So the cell has to discharge the energy that makes depolarization possible. Okay, so that means the heart is contracting now. And as the opposite, of course, will be repolarization, because after depolarization, of course, it lost all that energy, correct? Now it has to recharge again. So from negative, it starts becoming positive again. Okay, positive, positive, and then when it's fully charged, it will contract, and then the cycle goes over again. Okay, 60 to 100 times a minute. There are influences on heart rate. For instance, let's say emotion. Okay, so you're happy, you're sad, that has effects on the heart rate and also blood pressure as a consequence. So when you're happy or sad or mad, for instance, all right, so it changes your heart rate, correct? And the contractility of your heart. And it's all about sympathetic and parasympathetic stimulation. So as these hormones, the catecholamines, are released into your bloodstream, then they affect heart rate. Okay, so these are other factors that will affect it. So exercise, anxiety, or medications such as these mentioned here. Okay, so they have different effects on the contractility as well as the rate of your heartbeats. The ECG is a machine invented by Dr. Einthoven a century ago. So Dr. Einthoven developed a machine that will capture the electrical impulses traveling throughout the body. So he postulated that if you capture the electrical activity by placing certain electrodes, some of them are unipolar, some are bipolar. I won't discuss this part because it's a long story. Okay, I don't have time to discuss how an ECG actually works. But let me just show you the same figure as we did earlier. So let's look at figure. What is this? 22-1. Okay. So look at the triangle. So it's an upside down triangle, right? So this is called the Einthoven triangle. You'll see there right arm, then left leg. Okay, and there's really no right leg involved here because it's a triangle. So you see here the poles on each side. So there's lead one. The top of the triangle is lead one. The right side of this triangle is lead two. The left side of this triangle is lead three. And then you have your left arm, which is bipolar. You have a positive and a negative electrode, and then both negative on the right arm. Then you have two positives on the left leg. Now, this means that on a 12 lead ECG, if you count them total, there will be 10 electrodes. Okay, 10 electrodes, meaning you'll put in 6 chest leads. I'll show you the placement of the 6 chest leads will be 2 on each border of the chest, second intercostal space. Okay, so this is your sternum, correct? So 1 on each side of the sternum, second intercostal space. So that's B1 and B2. So lead 1, B1, B2, and then 3, 4, 5, 6 will be here on the 4th to the 5th intercostal. B6 would be mid-axillary. So that's a total of 6 chest leads, right? 1, 2, 1, 2, 3, 4, 5, 6. Okay, so you have 6 chest leads and then 4 limb leads, 1 on each extremity. So 1 on each arm and then 1 on each leg. So that's 10 total, right? But because the left arm is bipolar, meaning it carries 2 leads. Okay, not just 1. It carries both positive and negative. So that means, yes, you have 10 leads, but because of that bipolar lead, it will give you 12 different views. Now, when we say 12 different views, that's a 360-degree view of the heart. So think of a 12-lead ECG as 12 different photographers taking a picture of the heart at different angles. You imagine that so far? Okay, so let me show you a picture of a 12-lead ECG because there's none on your textbook. All right, so here's a 12-lead ECG. So there are 10 electrodes giving you 12 different views. Now, this is the same patient taken who has a 12-lead ECG. Okay, so you see here lead 1, lead 2, lead 3. And you got 4. All right. Okay, so you got lead 1, lead 2, lead 3. And then you got ABR, meaning right arm, ABL, left arm, AB foot is the right foot. There's really no AB left foot, okay, because the left foot is just a ground lead. Then you got B1, B2, 3, 4, 5, 6. That's 12 total, correct? All right. Now, most of the leads shown in your textbook come from lead 2. Now, look at again our illustration here. So why lead 2? Because which one is going in the same pathway as the electrical conduction. Lead 1, 2, 3, or right arm, left leg, which one? It's the lead 2. Okay, so lead 2 is the same direction as the electrical conduction pathway. So most leads you'll see on your textbooks come from lead 2. Okay. And all illustrations, therefore, when we discuss it, will be taken from lead 2 because we can't use the other leads. For instance, if you look at B1 or ABR, it looks inverted, correct? Because let's say ABR is taken from the right shoulder. So since the photographer sitting on the right shoulder taking a picture of the heart, will he see it this way or that way? So he'll see it that way because he's looking at it at a different vantage point. It's a different angle. So that's why it looks different. But that doesn't mean that lead ABR here is abnormal. No, it's all the same. This is normal sinus rhythm. However, again, they look different because they are taken from a different angle of the heart. Does that make sense? Okay. Just in case you're wondering why. So when I interpret, let's say I get a 12 lead ECG, I automatically look at lead 2. Okay, because this is the easiest one to read. However, doctors, especially if it's an abnormal rhythm, the lead where the abnormal rhythm occurs tells the doctor where exactly is the problem. So let's say it's a heart attack. So this will give the doctor an idea about where exactly, which artery does he think is blocked, which is causing the patient's abnormal rhythm. Does that make sense? Okay. Okay, moving on. So there are a few steps we need to follow when looking at a rhythm strip. And there are steps here. Chart 22-1. Now I won't follow all the way to 12. Okay, for us, again, we are basic nurses. We just need to know enough for the NCLEX. Okay, plus we only have less than 2 hours to finish this lesson. Okay, so chart 22-1. The first step in looking at a rhythm strip when you want to interpret what it is the rate, particularly the ventricular rate. And we look at a few methods in how to calculate the rate. Next is the ventricular rhythm. Now, when we say ventricular rhythm, we're not interpreting the rhythm itself. We're just looking at the ventricular rhythm. Number 2 means how often does the ventricles contract? Meaning, how often or what is the pattern, okay, of the occurrence of each wave and complex? Meaning, are they occurring regularly? So let's say it makes more sense when we look at the sample later. Number 3 is the QRS duration. You want to measure the QRS duration. Are they normal in measurement? Meaning, are they less than 0.1 seconds? Three and 4 are about the same. Next is the shape of the QRS. Are they narrow or are they wide, which is about the same as when you measure it? Next is the P waves. Now, the P waves are very important because the P wave represents atrial depolarization. Not only that, when we see a P wave, that means that the electrical impulse came from the SA node. Okay, so the P wave is very, very important. If there are no P waves, that means what? Let me repeat. When you see a P wave, that means 2 things. P wave means that the SA node fired or initiated the impulse, meaning the heartbeat came from the SA node. And another meaning is when we see a P wave, the atria, the left and right atria, contracted. Okay, so therefore, if you don't see P waves, what two things are missing? The contraction did not come from, or the electrical impulse did not come from the SA node. Where did it come from? Who knows where? But we know it did not come from the SA node. And what else did not happen when there is no P wave? The atria did not really contract. Okay? They quivered. Okay? They did something, but they did not contract. Are we clear? All right. And then atrial rate. The atrial rate is, since the P wave means the atria contracted, then we count the P waves. Okay. The PR interval. Let me explain what the PR interval is. Okay, let's look at this picture. Okay. Because it does that. Okay, let's use this figure. Okay. So you see this is figure 22-3. So this is an ECG paper. So an ECG paper has two sets of lines. So there are horizontal lines and there are vertical lines, correct? Okay. So that will help us. Now the horizontal lines measures time in seconds, whereas the vertical lines measures voltage in millivolts. I repeat, horizontal lines measure time in seconds. Vertical lines measure voltage in millivolts. Okay. Now let's look at the measurements. Let's look at the figure. So each tiny little, you see this arrow here? So there are, therefore, in the ECG paper, you see little boxes, yeah? Little squares, and then there's also a big square, meaning here, this is one big square right here. And inside this big square, there's a total of 25 small boxes in that small 25 squares. So there's 5 in each row. So 1, 2, 3, 4, 5. And that should be the same, 5 up. Okay. So since we're measuring time, let's just look at the horizontal axis. So if each small square or small box is 0.04 seconds, so times 5, that means one big box is 0.2 seconds. All right. So therefore, how many big boxes do you think will be there in 60 seconds, in 1 minute? So 60 divided by 0.2 equals? What's the answer? So 60 seconds divided by 0.2 seconds equals? 300. Okay, so there are 300 big boxes in 1 minute. How about small boxes? So if each small box is 0.04 seconds, how many small boxes are there in 1 minute? So 60 seconds divided by 0.04 equals? 1,500 small boxes. All right. Okay, so remember those numbers for now. Okay, we'll look at them later when we do an example, okay, of how to count the heart rate. Again, how many big boxes are there in 1 minute? 300. And how many tiny little small boxes are there in 1 minute? 1,500. Okay, very good. Now let's look at the waves and complexes. So we're still on the same figure, 22-3. So you see here waves and complexes, right? So let me introduce you to the P wave. So this is the P wave. How we measure each wave is pretty simple. You see an isoelectric line. Yeah, isoelectric line meaning it's a flat line. Okay, it's a straight line. So this one is an isoelectric line, correct? Okay. So the isoelectric line is an imaginary straight line from which each wave leaves the isoelectric line and then returns to that same isoelectric line. Now, unlike this figure 22-3, which is drawn, obviously, right? This was drawn by an artist. Now, let's look at an actual ECG tracing, which is on this figure. Okay, so this is an actual ECG tracing. Do you see the isoelectric line falling on a solid line? No, because on a real person, you and me, it never falls on a solid line. Never. It's always in some imaginary straight line. So you just have to eyeball it. So this one, the isoelectric line, I would say is somewhere here. You agree? Right here, somewhere here. Not exactly on this solid line, but a few boxes below that is the isoelectric line. You understand what I'm saying? Okay. So now that's important to find the isoelectric line, because otherwise you'd have a problem measuring the P wave or any wave for that matter. So let's look at this example. So the P wave is this wave right here. What does the P wave represent again? Electrical impulse came from the SA node, and what's the other meaning? The atria contracted, both atria contracted. Okay, so we measure the P wave from when it left the isoelectric line to where it returned to the isoelectric line. So we can say the P wave came from here to here, correct? That's the P wave. Okay. Now the measurement of the P wave is not really significant, more so the shape of the P wave. Okay. So the P wave, again, this is drawn. Now on a real person, the P wave will look sharp, like this, for instance. So this is what a P wave would actually look on a real ECG. Okay, you see this? That's the normal shape of a P wave. It's not really round. Okay, I never see a round, the tip of the P wave is never round. It's actually sharp. Okay, so if they look like these, okay, that's a normal P wave. All right. Okay, next. Let's measure the PR interval. Don't get confused by the term PR interval, because look at the wave. So this is the P wave, this is the Q, R, S, and then the T wave, and then the, let's disregard the U wave. Okay, U wave is not really significant. 9 times out of 10, you never see the U wave. Okay, no, more like 1 is to 1,000. Okay, so no, that'd be 1,000 to 1. Okay, so 1,000 times, probably the U wave will appear in one patient. All right, and if you have 1,000 patients, only one of them will show a U wave. Right? It's not really, but of course the U wave is present only in, let's say you have a low potassium. Usually, that's the cause of a U wave. And a few other things, but again, the U wave is not always there, so it's not really that significant. Plus, we have other ways to find out if the patient has an potassium abnormality anyway. Okay, so the P wave. Any question about the P wave? Okay, so what 2 things are happening when we see a P wave? The SA node fired the electrical impulse, and the atria, both atria contracted at the same time. If you see a P wave, you know 2 things happen. Yeah. Okay. Now let's measure the PR interval and discuss what does it represent. Okay. So the PR interval has nothing to do with the R wave. First of all, the PR interval is actually measured from the P wave, meaning it includes the P wave, to right before the Q wave starts. I repeat, the PR interval is measured from the Q wave to just before the Q wave begins. All right, its normal measurement is 0.12 to 0.2 seconds. I repeat, the PR interval is measured from the P wave to just before the Q wave begins. Okay, so therefore, since the Q wave started here, that's the end of the PR interval. All right, what's the normal measurement? 0.12 to 0.2 seconds. Okay. So it's from here to here. Now, what is the significance of a PR interval? Now, imagine the cardiac cycle. So if the atria contract here, let me show you on this figure here. Oh, no, sorry, same. Okay, let's go back here. So if the SA node fires, you see these branches right here, okay, going to the right left atrium. Okay, so those are called sinoatrial interatrial branches, meaning when the SA node fires, it reaches the left ventricle instantaneously, and then both atria will contract at the same time, no delay. Both atria will contract and therefore push blood into the ventricles, correct? The right atrium pushes blood to the ventricle, to the right ventricle, and the left atrium pushes blood into the left ventricle. Okay, that's what's happened. You see what wave again when this happens? The P wave. Okay, all right. Now imagine an electrical impulse. You've seen lightning. So we had storms last night. They were pretty bad lightning strikes, yeah? Okay. When you saw the lightning strike, did it take a long time for it to appear from the sky and then hit something in the horizon? Did it take long? It happened instantaneously, right? It's like diarrhea. So when you thought, oh, something diarrhea, oh, next thing you know, it's already in your underpants, yeah? Oh, crap, it's already there, right? Or light switch, okay? When you switch on the light, oh, it's already there, okay? So light switch, you know, another analogy, yeah, the diarrhea, for instance, okay? Or a thought, okay? Thought just comes on, yeah? Really fast. So therefore, if you think about it, this is like a lightning strike, correct? This is electricity. So the SA node fired an electrical impulse. So you think it will take long before the SA node electrical impulse to reach the Purkinje fibers? Just like lightning? You think it will take long? No. However, if it does transmit the electrical impulse from the SA node to the AB node, then to the left and right bundle branches, all the way to the Purkinje fiber, what will happen? Will not the atria and the ventricles contract at the same time as a result? That's exactly what will happen, all right? But however, it does not happen in our hearts. What happens is there's a delay. The PR interval represents that delay, meaning every electrical impulse, when you see a P wave, and then you measure the PR interval, the PR interval is the time period of delay, meaning it takes 0.12 to 0.2 seconds before the electrical impulse reaches the Purkinje fibers. Now, who did that? Who delayed the electrical conduction? It was the AB node. Okay, so the other job of the AB node, besides being a backup pacemaker, meaning it's a secondary pacemaker, yeah? Its other very important job is to delay the transmission of the impulse coming from the SA node, right? Because the SA node, once it fired, of course, yeah, the electrical impulse will reach the Purkinje fibers instantaneously, but it does not happen because the AB node delays the transmission of the impulse. It holds on to the electrical impulse, holds it for how long? 0.12 to 0.2 seconds. It delays it Meaning, what happens during that delay? Because again, if the AB node did not delay the electrical impulse transmission, will not the SA node electrical impulse reach the Purkinje fibers right away? Yes, and then as a result, both the atria and the ventricles will contract at exactly the same time. What will happen if that happens? What's the result? The atria, imagine if your atria and your ventricles contract at exactly the same time. Will blood ever move? It'll be chaotic, right? What is supposed to happen? Atria should contract first, push that blood into the ventricles, and then the ventricles will contract and then push the blood. The right side will push it to the heart, the left side will push it to the aorta. Then we have cardiac output. So imagine, if there is no delay, will there be any blood movement throughout the heart? Will you ever have cardiac output? Will you have any blood pressure? Nothing. So is the PR interval important? Yes. Who makes the PR interval possible? The AV node. Okay. So the AV node delayed the impulse transmission. So as a result, we have the PR interval. So is the PR interval important? Okay. Now imagine if the heart rate, so I know we haven't counted the heart rate yet, but in this example here, for instance, in this example, it's not cooperating. All right. So this is a normal heart rate. Okay, so this heart rate, I'll explain why later. So this is a heart rate of in the 80s. Okay, so the heart rate here is less than 90. So normal, right? Between 60 to 100 beats a minute. Imagine if the heartbeat is 120 or even 200. Will it still look like this? No, because that means each heartbeat will be packed closer together, correct? Okay, so what happens to the PR interval the faster your heart rate becomes? Will it still be 0.12 to 0.2 seconds? No. So therefore, once your PR interval shortens, what happens to cardiac output? Why? There's not enough time for what's happening again during the PR interval, during that delay? What's happening? The blood are filling the ventricles. Okay, blood is filling the ventricles during the PR interval. If you think about it, correct? Okay. So therefore, the shorter your PR interval, the blank your cardiac output. The shorter your PR interval, the blank your cardiac output becomes. The lower your cardiac output becomes. Okay. Any questions so far? Okay, let's proceed. So we know the P wave, we know the PR interval. Let's look at the QRS complex, which is the next waves. So you have here the Q, the R, and the S. QRS complex represents ventricular depolarization, or simply ventricular contraction. So the ventricles contracted when you see a QRS complex. Okay? So you can just imagine remember the vertical axis is, what does the vertical axis measure again? Voltage, right? The amount of electricity, the amount of volts, okay, in millivolts. Compare the P wave, the QRS complex, especially the R wave, and then the T. You can just imagine how much power was discharged, right? When the ventricles contracted. Look at how much power was discharged when the atria contracted. Very little, right? Very, very low voltage. But look at the power during ventricular contraction. So it's what? 1, 2, 3, 4. Over 5 times stronger. Okay, almost 6 times stronger. Okay, compared to the atrial contraction. Right? So when you see the QRS complex, what's happening? The ventricles are contracting. Right? And the measurement should be less than 0.1 seconds or 0.10 seconds. So how much is each small wave again? Small box, sorry. 0.04 seconds. So measure the QRS complex here. So QRS duration is how many seconds? Approximately 0.06, yeah? Approximately. Because if each one is 0.04, that means both will be 0.08, yeah? But it didn't reach 2 small boxes. Yeah, it's less than 2 small boxes. So approximately 0.06, okay? That's normal, right? Then let's look at the next wave, which is the ST segment. S wave is from here, and then the T would be here, okay, because this is the T wave. So remember, we measure from the beginning of one to right before the next one begins. So the ST segment is here. This isoelectric wave here, meaning flat isoelectric, is the ST segment. Now, what's happening in the ST segment? This is basically the heart is resting because there's no electrical activity. It's flat. So if you're asking, does my heart ever rest? Yes. That's it. Your heart rests there for how long? About 0.04 seconds. That's all it can afford to rest. Okay? And then the next wave is the T wave. This is now ventricular repolarization, meaning the ventricles are becoming more positively charged, getting ready for the next contraction. And there's your cardiac cycle. This is 1 heartbeat. Okay, so the PQRST is 1 heartbeat. So who can volunteer to tell me what's happening? PQRST. Who wants to volunteer? What's happening in P wave? AC node fired, and then the atria, both atria contracted. Next, what's happening to the Miss Dankwa? PR interval, what's happening? PR interval, this whole period here. Yeah, but let's just tell me, what is the significance of a PR interval? What does it represent? A delay from the transmission of the impulse. Okay, meaning, yes, the SA node fired here, but the AB node did not transmit it to the bundle of His and the Purkinje fibers. Yeah, it delayed the transmission by how long? 0.12 to 0.2 seconds. So let's measure this example. How long is your PR interval in this example? Remember, each small box is 0.04 seconds. And how many small boxes is this? Because it's from here to here. So we got 3 here, right? 1, 2, 3, and is this half of a small box? Yes, so this would be about 0.02, yeah? Plus 3, I know 3 would be 0.12 plus 0.02 0.14. So is it between 0.12 to 0.2? Yes, it is. So it's normal, yeah? Okay. And what's the next wave, the QRS complex? What does that represent? The contraction of the ventricles. And then what's happening with the ST segment? Okay, nothing. Okay, nothing's happening there. So therefore the heart is technically resting. Yes, zero electrical activity. It's isoelectric. And then followed by the T wave. What's happening in the T wave? The ventricles are repolarizing. Okay, getting ready, getting more positively charged again, getting set for the next heartbeat. Okay, which isn't very long. Yeah. And there's your cardiac cycle. Any questions? Yes. Yeah. Very short period, but yeah. But can you see the significance though? Do you really want your heartbeat to be really fast? No, because what's happening? What's the heart doing when it's beating more than 100 beats per minute? Working hard, yeah, working hard. We can sustain that periodically, let's say you're exercising, yeah, so that's okay. But imagine if you're running all day, how much workload is that on the heart? Okay, so for me, I'm taking care of my heart by sitting on the couch and using the remote control. Okay, so that's how I care for my heart. I want it to rest. Okay, let's take a break.